My presentation today is about heart failure with preserved ejection fraction and mid-range ejection fraction, what is new in treatment. Heart failure is defined as a complex clinical syndrome with symptoms and signs that result from any functional or structural impairment of ventricular filling or ejection of blood. According to ECC guidelines, heart failure is classified into three categories according to LV ejection fraction. Heart failure with reduced ejection fraction less than 40%, mid-range between 41 and 49%, and heart failure with preserved ejection fraction equal or more than 50%. In all categories of heart failure, the symptoms and signs of heart failure must be present in addition to functional or structural abnormality of the myocardium. The first issue in my lecture is the treatment of heart failure with preserved ejection fraction. The treatment includes different lines of therapy. The first one is drug therapy. None of the previously conducted large randomized controlled trial in heart failure with preserved ejection fraction have achieved their primary endpoints, mainly the cardiovascular reduction in the cardiovascular mortality. These include PEP congestive heart failure for prendopril, SHARM preserved for candesartan, I-preserve for irbesartan, TOPCAT for spironolactone, DIG preserved for digoxin, and Pragon heart failure for sacubitril valsartan. However, some of these trials show some sort of reduction in heart failure hospitalization, but no reduction in the cardiovascular mortality. Trials targeting nitric oxide cyclic guanosine monophosphate pathway have also failed to improve exercise capacity or quality of life in heart failure with preserved ejection fraction, like NEAT heart failure for oral isosapide mononitrates, ND for inhaled inorganic nitrites, Vitality for Veriswegat. Treatment should be aimed at reducing symptoms and signs of pulmonary congestion using diuretics. Loop diuretics are preferred, being high-ceiling diuretics, but also thiazide diuretics may be needed in those with hypertension. Identification and treatment of specific causes such as amyloid and management of comorbidities like hypertension, coronary artery disease, and atrial fibrillation is the mainstay of treatment. However, the optimal blood pressure goal and antihypertensive regimens aren't known for patients with heart failure with preserved ejection fraction. RAS blockers, including ACE, ARBs, mineralocorticoid receptor antagonist, and ARNI, could be first-line agent for treatment of hypertension based on their use in the previously conducted trials. Beta blockers may be used in heart failure with preserved ejection fraction to treat hypertension, in addition to those with history of myocardial infarction and symptomatic coronary artery disease, and those with atrial fibrillation with rapid ventricular response. However, a recent small open-label trial called RATE atrial fibrillation trial conducted in elderly patients with atrial fibrillation and symptoms of heart failure. The trial was done to compare the use of beta blockers, bisoprolol, with digoxin in those with atrial fibrillation and preserved ejection fraction. At 6 months follow-up, the primary endpoint of quality of life was similar between both groups, and there was also a similar heart rate reduction in both groups. However, more adverse events related to hypertension, like dizziness and lethargy, occurred more frequently with beta blockers than digoxin. Here we will present some of large trials conducted in patients with heart failure with preserved ejection fraction. The first trial, the largest trial called Pragon heart failure, that was done to assess the efficacy of angiotensin neprilysin inhibitors in those with heart failure with preserved ejection fraction. The study was conducted on 4,800 patients, NIHA function class 2 to 4, ejection fraction 45% or more, randomized to receive sacubitril valsartan or valsartan. The primary outcome was a composite of heart failure hospitalization and cardiovascular mortality. The secondary endpoint, improvement in NIHA function class and worsening renal function. And it was found that sacubitril valsartan didn't result in a significant reduction of the composite endpoint of heart failure hospitalization and cardiovascular mortality. But there was some sort of reduction of heart failure hospitalization with borderline significance. P-value was around 0.05. The second trial is Emperor preserved trial for empagliflozin in those with heart failure with preserved ejection fraction. It was a double-blind randomized trial done on 5,900 patients, NIHA function class 2 to 4. Ejection fraction 40% or more. They were randomized to receive empagliflozin 10 mg once daily or placebo. The primary outcome was a composite of cardiovascular death or hospitalization for heart failure. And they found that empagliflozin reduced the combined risk of heart failure, hospitalization, and cardiovascular mortality by 21%, regardless of presence or absence of diabetes. However, the main benefit was related to reduction in heart failure hospitalization in empagliflozin group. No reduction in the cardiovascular mortality and no effect on all-cause mortality. The third trial is DELIVER trial, done to assess use of dapagliflozin in heart failure with mildly reduced and preserved ejection fraction. The study was done on 6,000 patients with heart failure, ejection fraction 40% or more, randomized to receive dapagliflozin at a dose of 10 mg once daily or placebo. The primary outcome was a composite of worsening heart failure or cardiovascular death, and it was found that dapagliflozin reduced the combined risk of heart failure and cardiovascular, hospitalization, and cardiovascular mortality among patients with mildly reduced and preserved ejection fraction. Based on the previously mentioned trial, the American Cardiology of Guidelines released these recommendations. Patient with heart failure with preserved ejection fraction, hypertension, patient with hypertension should have medication titrated to attain blood pressure targets in accordance with published clinical practice guidelines. Sodium glucose co-transport inhibitors based on the DELIVER and Emperor preserved trial received the class 2A recommendation for those with heart failure with preserved ejection fraction to reduce post-mortality and morbidity. Management of atrial fibrillation can be also useful in those with heart failure with preserved ejection fraction to improve symptoms. Mineralocorticoid receptor antagonist may be considered to decrease hospitalization in those with heart failure with preserved ejection fraction, class 2B. ERBs and ARNI are also may be considered to reduce cardiovascular heart failure hospitalization among those with heart failure with preserved ejection fraction on the lower end of the spectrum of ejection fraction. The second line is device therapy. The rationale for use of device therapy is reduction of the left atrial pressure in those with heart failure with preserved ejection fraction. This is expected to improve symptoms. And this can be achieved by implantation of intra-atrial shunt device and monitored by invasive hemodynamic measurement of pulmonary capillary wedge pressure. Here, this the first trial, reduced lab heart failure trial. It was a double-blind, multi-center trial, was done to assess the efficacy and safety of using intra-atrial shunt device in those with heart failure with preserved ejection fraction, NIHA function class 3 or ambulatory function class 4 heart failure patient. Included patient had ejection fraction 40% or more, pulmonary capillary wedge pressure equal or more than 25 millimeter mercury. The procedure was safe with long-term patency of the intra-atrial shunt, but the study was underpowered due to small number of patients included in the study. So a larger trial called Reduce Lab Heart Failure trial, it is now an ongoing trial done with a larger number of patients, longer term of follow-up to settle this issue in those with heart failure with preserved ejection fraction. The third line of treatment is optimal exercise training regimen. The hypothesis is that different modes of exercise had different effect in peak oxygen consumption and may achieve some of benefit for those with heart failure with preserved ejection fraction. However, a prospective multi-center trial assigning heart failure patient to different treatment groups, including high intensity interval training, moderate continuous training, and guideline-based physical training, failed to achieve any benefit in those with heart failure with ejection fraction. The second issue in my lecture is the treatment for those with heart failure with mildly reduced ejection fraction. Really, no trials was done to focus individually for patient with heart failure with mid-range ejection fraction. However, we will present some of recommendations released by American Society of Cardiology guidelines based on the previously mentioned trials that include patients with heart failure with mid-range and those also with preserved ejection fraction. The first recommendation, the first line of therapy include drug therapy that include diuretics to improve symptoms and signs of heart failure, class 1 level of evidence C. Sodium glucose co-transport inhibitors based on the previously mentioned trials received the class 2A recommendation to reduce post-heart failure hospitalization and cardiovascular mortality among those with heart failure with mid-range ejection fraction. Regarding AC inhibitors, no specific trials for those with mid-range ejection fraction. However, in PEP heart failure trial, there is a reduction of cardiovascular morbidity, reduction of heart failure hospitalization, and so AC inhibitors received the class 2B recommendations for those with heart failure with mid-range ejection fraction, like those also with preserved ejection fraction. Beta blockers, they also received class 2B recommendations. They may be considered for those with heart failure with mid-range ejection fraction to reduce the heart failure hospitalization and death. Mineralocorticoid receptor antagonist in the TOPCAT trial, the MRE failed to reduce mortality. However, there was some reduction of heart failure hospitalization. So MRE received the class 2B recommendation for those with heart failure with mid-range ejection fraction, class 2B recommendation. Angiotensin receptor neprilysin inhibitors, like mentioned in the PRAGON heart failure, no reduction in the composite endpoint of mortality or hospitalization. But it was found that there is some sort of reduction of heart failure hospitalization, particularly for those with ejection fraction 57% or less. And based on this data, sacubitril valsartan may be considered for those with heart failure with mid-range ejection fraction to reduce hospitalization, class 2B recommendation. Other drugs like digoxin in DIG trial, digoxin reduce the heart failure hospitalization, but no reduction in mortality. No data regarding ivabradine use for those with heart failure with mid-range ejection fraction. The second line of therapy is device therapy. There is no sufficient data to advise CRT or ICD for those with mid-range ejection fraction. And as mentioned before, regarding use of intra-atrial shunt device, there is an ongoing trial, reduced lab heart failure trial, done on large number of patients with long-term follow-up, but the issue is still unresolved. Thank you very much.